Okay, so today was our first day of hospital rounds, and I rounded in anesthesia with Dr. Alex. Here they don't like to be called like doctor like by their last name, so I was with Alex pretty much. My shift ran from 8 a.m. to 3 p.m. today. I observed 5 surgeries. In anesthesia here, they use 2 different machines. The first machine basically is like the pulse ox and BP and like the EKG heart rate and the CO2 for like general anesthetic. Machine 2 is like respirator like, and it's also for general anesthetic, and it measures volume, pressure in the airway, respiratory cycle, and the fraction of oxygen being admitted into the patient. The different types of anesthesia are general, intravenous, and gaseous. It can be intubated in, and there are short and long-lasting anesthesias. The short-term anesthesia is it's lidocaine, and it's pretty much used to like numb for like the spinal anesthesia. Long-term anesthesias last like 2 to 3 hours. The short-term are like 30 minutes to an hour. They use hyperbaric, bupivacaine, and then there's 3 different kinds of bupivacaine. That's the dosages, and then tachypril. And then like the epidural like anesthesia they use is ropifica, Cabi, and the Cabi is hydrochloride. So the anesthesiologist asked questions about like the diseases that they have, like the medicines they're taking, the allergies, and past surgeries, like before admitting the anesthesia. So the first patient surgery that I sat in on was all of these are urological surgeries, and he had a cyst. So there was local anesthetic, and it was like the spinal tap kind, where it's like similar to an epidural in between L3 and L4. The patient had COPD along with diabetes. So the local anesthetic goes like into the dura mater, and then like when you start to see the spinal fluid drip, that's when they then mix it with the anesthesia and then like reinsert it. They inject it. So patient 2's was bladder surgery. He had diabetes and hypertension, which is high blood pressure, and he was a past smoker. Now apparently there are different levels like looking into the mouth, and the anesthesiologist needs to know that for if they need to be intubated. And they actually have this like cannula that goes in, and you're not like fully intubated. It just like covers the epiglottis to push oxygen through. So this patient was a level 3 because you could see the tonsils and the uvula and the soft palate. And then you like measure the extension and like the distance of the neck from like right here. And 6 centimeters or more is okay. Less is like really bad. Like you need to pay close attention. They also measure like the distance between the teeth. And this patient had a catheter. So before the spinal anesthesia, the patient is sitting, the pulse ox is on, as well as the BP. Now, this patient had spinal anesthesia for an endoscopic bladder surgery. He was given Proferol during the surgery, and Proferol and along with fentanyl. And the fentanyl was to calm him down. He did have the cannula inserted into this one due to a cough after he was already sedated. So we gave him a higher amount of Proferol. The depth of anesthesia usually runs between 40 and 60. And he was prescribed cannula O2 for after surgery. Patient 3, I actually shadowed the nurse anesthetist. Yeah, that didn't come out right. And it was a block anesthetic. I actually have like a picture like in the book, but they were like, it was for shoulder surgery. So I like watched them do the ultrasound like with ultrasonic technology. And go through and do the local anesthetic to like pretty much just numb the shoulder. I did not witness that surgery. Patient 4 was a multiple prostate biopsy with a closed needle. The patient had a chest x-ray and blood tests before this surgery. The anesthetic was intravenous, so through the vein, and it was a general anesthetic. The patient usually goes home 2 to 3 hours after the surgery because it's very minor. He was given atropine, fentanyl, and Proferol. The Proferol is for sedation. The fentanyl is for pain. It's in the same family as morphine. And the atropine stops the bradycardia caused by the other two. The patient must urinate, eat, and ambulate or stand and walk before being released. There was a cannula inserted, but it was a different cannula. It was just used to compress the tongue to prevent the airway from obstruction. This patient was also prescribed an anti-inflammatory and acetaminophen after surgery. Patient 5 was a closed needle prostate biopsy as well. This patient was non-fasting, so he had to have spinal anesthesia, and he had no intravenous drugs during the surgery due to him being non-fasting. The patient also has diabetes, slowed peristalsis, and gastroparesis. We did our last round to check on the patients, and we had one patient that had major bradycardia, which is slow heart rate. His heart rate was of 30. A normal heart rate runs between 60 and 90. He also had major hypotension, which is really low blood pressure. His was 58/40. Normally we say 120/80. So we gave him adrenaline, atropine, and ephedrine, and he then became stabilized. So, like, all in all, it was an interesting day. The doctor I was with, like, the language barrier was not as bad as I thought it was going to be. He spoke very broken English, but what little knowledge of Spanish I had and the little knowledge of English he had, we communicated very well. Other than that, I'm looking forward to tomorrow. Dr. Alex said that we will be doing trauma surgery, and, like, trauma surgery here is more like orthopedic, so like inserting rods and pins, and I will have my next video up tomorrow. And also, what time is it?
It is 5:54.
So right now it is 5:54 local time here in Almanza, Spain.